So acute kidney injury, this is part of your threats to elimination, and it's part of chapter 46. So what is it exactly? Well, it's a rapid loss of kidney function. And we'll talk about different ways that it can be lost. But it's a rapid loss. Whether it's a blockage or whether it's lack of blood flow, lack of perfusion, it's usually pretty rapid. So let's first talk about the kidney. We're going to do a quick review of the amazing kidney because it is amazing. I will tell you, kidney was never my favorite topic. But as I have really learned more and more about it, it is truly amazing. And what makes it so amazing is that it can filter about 1 liter of blood per minute. So within a few hours, or less than an hour, your kidney can filter your whole body's blood. So I think that's pretty amazing. So what does that mean exactly? What is it? What are they doing? So you got your blood coming in through the renal artery. I drew an arrow. So you've got blood that comes in, and then you also have blood that goes out. So when it goes in, there's all this amazing process that happens that filters the blood, that excretes waste or gets rid of waste, and then there are like electrolytes and hormones that are reabsorbed because the body needs them. So it's really an ultra process that is really marvelous. So you've got your ureter, which is where your urine flows out of, right? So within each, so this whole kidney, you've got 2 kidneys. Most people do. And you can live well with just one, which is really amazing as well. But because you have so much of a vascular network in there, that's how you can live with just one kidney. Let's see. Now, I put a couple of different pictures here because I like the way the one on the far left over there, that's your glomerulus, and I like the way just the way it's showing you that's where your filtration happens there in the glomerulus. But I like the middle picture because that picture is a more in-depth picture of what is really going on. So I'm just going to try to give you a quick overview here. I'm going to make this bigger so you can see it a little better. So like I said, your glomerulus is your filtration. But then you've got this you've got this proximal tubule here. That's like where your electrolytes are reabsorbed, amino acids, glucose, and then down here you've got your loop of Henle. What do you think happens there? You think that's where loop diuretics are? What did you say, Taylor? Water's reabsorbed, and that's where your loop diuretics act as well. So that's where water's reabsorbed and kind of stuff's concentrated as well. And then you've got your distal tubule and your collecting duct here. Your distal tubule, secretion of potassium, hydrogen, ammonia, reabsorption again of water that's regulated by ADH. So I'm not telling you all this so that you can memorize all this or that you really need to know this particular information for the renal content, but you need to know this information because it will help you understand, like later in the lecture, you're going to say, I really don't understand how they can be having calcium deficit or something like that, or well, you got to figure out what part, there's part of the kidneys not working. So maybe the proximal tubules, not working right. So you're having some problems with electrolytes. So the whole purpose of me going over all this is just so you can kind of get in your mind that different things happen within different parts of the kidney, within different parts of this filtration system. Okay? So sometimes you can have an electrolyte imbalance, and you're thinking, why? I don't really understand it. Well, there's probably damage there, or there's the kidney's not processing it correctly in that area. So that's the whole purpose. That's why I wanted to kind of go over all that with you. That should be a review probably from anatomy. Some of you might have taken anatomy a while back. But but anyway, so that's just why I want to go over it, is that, each little area there has its jobs, different jobs. But your glomerulus is where the filtration happens. And it filters the blood, and it's got these little microscopic units that do this filtration. So overall, the kidney kind of regulates your urine and the composition of your urine. When I say composition, we go back to your glucose, your electrolytes, your amino acids, your bicarb. So it regulates volume and the composition, and then it also excretes waste. And because with the regulate volume, that's where your filtration happens, and the composition, that's where your reabsorption, your excretion, your secretion. Because not only does it get rid of it, sometimes it secretes some of the hormones back for use. So you remember when I was talking about, not that bicarb is a hormone, but you remember I was talking about bicarb when we were talking about the ABGs, and the kidneys not only make it, but it also reabsorbs it. So that's kind of an example of what it does as far as a composition and secretion. So let's get a little bit more into what you need to know. So the functions of the kidney as far as this content particular. So what does it do? Well, it regulates the production of erythropoietin, right, or erythrocytes. That is erythropoietin is a hormone, right? And it's produced in the kidneys. And it stimulates the bone marrow to produce red blood cells. So that's the important part. The whole thing's important, but you got to kind of understand that it's a hormone, and it stimulates red blood cell production in the bone marrow. Not only does it do that, but it also regulates your blood pressure. The kidneys do that, and with the heart, but regulation of your blood pressure by excreting sodium, by renin. So here we are back to this whole renin, RAS, renin, angiotensin, and aldosterone system. Well, right here in the kidneys, when it senses low sodium or low volume, then your renin, your RAS system is activated. What is RAS? Well, that is where your body is trying to keep homeostasis. It's trying to bring your blood pressure up because there's something going on. You're most likely hypovolemia, or there's not enough perfusion to the kidneys. So it regulates your blood pressure. And then as far as the helping regulate the acid-base balance, like I said, it buffers your bicarb, and it regulates your pH. And then, of course, elimination of your toxins, your waste through urine, right? And so your BUN is your end product of protein metabolism, and your creatinine is your end product of muscle metabolism. We're going to talk a little bit more about, when we talk about uremic and all, the buildup of toxins, we're going to talk a little bit more about how the waste, like the process of the waste. The excretes sodium. In the regulation of the blood pressure, excretes sodium, Na. Oh, I was making it bigger for me, but y'all can't make it, doesn't get bigger for you. Whoops. Oh, the kidneys also, you got your bone over here. This is like a bone. If you're wondering what that picture is there. But it regulates mineral levels because the kidneys activate vitamin D for absorption in the GI tract. So they do a lot. Back to the amazingness, right? So they activate vitamin D for absorption in the GI tract. So overall, it maintains homeostasis in the body. Does everybody have that? All right, so I put this chart here, and this is might be something we fill out in the module. I think you can get everything from the for that, but it's a chart 47-1 in your book. No, 46. That's the old, isn't it? It's on page 1070. And it is just kind of comparison of acute kidney injury with chronic. And why do you think that's important? Well, it's important that you know the difference. Acute kidney injury is sudden, chronic's gradual over years. Acute kidney injury, most common cause is acute tubular necrosis. So basically, the tubules are sloughing off. They're damaged. So they're necrosing. You're getting cast. You're getting damaged. So that's your most common cause. As far as chronic, diabetic neuropathy. And then your acute kidney injury, what are you going to see? A drastic drop in urine output. Whereas acute kidney, chronic, you're going to be looking at the GFR. Someone with diabetes or heart disease, most of the time diabetes, they're going to be monitoring their GFR. So that's what they look at. And then also with acute, elevation in serum creatinine. And acute, the reason why this says kidney damage greater than 3 months, well, acute can turn into chronic. If it's not corrected, and they're just going on damage for 3 months, then they can have chronic. So the good news is acute kidney injury is reversible. It is. If they find what are we doing? Treating the underlying cause. What's going on with the patient? What's blocked? Is there a tumor blocking something? Is there a lack of blood flow somehow? So it is reversible. Whereas chronic is not reversible. It's irreversible, it's progressive. this is the reason why I even thought this was important. It's important because we're not going to ask you which one is sudden, acute, or chronic. No, we're going to expect you to know. It's going to be like you have a patient and they were brought into the ER and their blood pressure is 80/40, and what do you think? Do you think the patient could be going into, they don't have any urine output for 4 hours? Do you think the patient's in acute kidney injury or chronic kidney disease? That won't be a question either, but it'll be something like that. It'll give you scenario. It won't necessarily be black and white is what I'm saying. It'll be more of a scenario. So it'll say, let me think of another one. So you've got a patient and you're working on the med-surg floor, and your patient, all of a sudden, they had surgery 2 days ago, and all of a sudden you get the results back and they have positive CAST in their urine. CAST, C-A-S-T-S. What would be your concern? Kidney failure, acute tubular necrosis. So it'd be like that. That's why it's important. That's why I kind of stress this. Even though you might not see any kind of test question right from this, but they're going to ask you something about acute tubular necrosis. You're going to have to know that's what happens sometimes with acute kidney failure. So that's why I go over stuff like this. Okay. So what are some causes? I like this. This is not from your book. There is a good one in your book that I have as well. But I really like this one because it kind of gives you a short, some reasons on each one. So the first one is pre-renal, and it's got a number 1 there. As you can see on the thing, number 1 is pre-renal. So any kind of blood flow problem, even something with the renal artery, like a renal artery stenosis or renal artery thrombosis, anything that's blocking that blood flow to the kidney. Something with your aorta, like a AAA, right? Or aortic stenosis. Anything, and something as easy as hypovolemia, where you're not getting enough flow. So that is sudden and severe drop, right? Like shock. And then number 2, your intrarenal. So with intrarenal, you want to think inside the kidney. Inflammation, toxins, drugs. What's a drug that harms the kidneys? Vanco. Gentamicin. Contrast. Contrast media. Someone that's getting a CT scan with contrast. If they already have some decreased blood flow to the kidney, would you want to do that? Probably not. I remember when I was talking to you all about cath, the cath lab. They use contrast media in the cath lab. Well, if they had some kidney damage, if their creatinine was elevated, or they had some chronic kidney disease, the doctors would sometimes, they wouldn't even, if they needed 2 stents, they wouldn't do both of them. They'd only do one because they didn't want to have them exposed to all that contrast media for so long. So it's not good for the kidneys. And then 3, post-renal, just like it says, below the kidney, right? So you got number 3 here. You see your ureters, your bladder, your prostate, your urethra, anything like that would cause any kind of outflow problem. Urine can't get out, so what does it do when it can't get out? Goes back up, right? So then you can get your damage to your kidneys and to your parenchyma, which is your tissue, right? So post-renal, sudden obstruction of renal flow. What are some of those?
Kidney stone.
Kidney stone, BPH, prostate, or swollen prostate, reflux, tumor. All right, so what we didn't talk about one thing, intrarenal. We didn't name something that I wanted you to think about. What do you think? Damage to the inside of the kidney. Think autoimmune, right? Systemic lupus. What else? Anything, any kind of autoimmune that's going to damage your kidneys, right? Or think of the damage to the not only to your vessels inside the kidney, your vascular, but you want to think any kind of damage even to the tissue, your parenchyma there. So, which can end up causing inflammation and damage to the other parts. Let me see. For toxins. Again, I know it feels like I'm beating a dead horse, but this is important to know. It's important that you get these concepts. So intrarenal, prolonged ischemia, nephrotoxic drugs, destruction of the tubular epithelium.
So what's the difference between the pre-renal causes decreased blood?
Again, below the kidneys. I like this one too because it's more of a visual, and it's in your book. But it actually is colored in your book, and it shows you, what its effect. So, pre-renal, your heart, anything to do with your heart, could cause pre-renal. Anything to do with the pipes above the kidneys. And then intrarenal, anything to do within the kidneys, and then postrenal is outflow. What do you think? Someone that's paralyzed with a neurogenic, am I saying that right? Neurogenic bladder? Neurogenic. Postrenal, right? Right. Their bladder's not working. Yes. Problem. You got an outflow problem. Can't talk. Sorry. Prolonged ischemia, nephrotoxic drugs, ATM, which is acute tubular necrosis, lupus, and I spelled it wrong. I just wrote LUPS, but it's lupus. And we didn't talk about this, a blood transfusion. See, I remember back from test 1, a hemolytic reaction to blood transfusion can cause intrarenal damage. So, let's talk about clinical manifestations. What are we going to see? Well, of course, we are going to see a reduction in urine. And that's called oliguria. I believe your book says less than 400 is oliguria, right? Yep, urine output less than 400.
Less than 400 milliliters in a day?
Yep, less than 400 milliliters in a day. Yep, 24-hour period. Azotemia, the accumulation of the nitrogenous waste, right? In the blood. increased BUN, increased creatinine. And then I start writing about I write a little bit here on a little bit of your rifle here. Your rifle is your, in your book, rifle table, page 1071. Again, this is not, we're not going to ask you, is your patient at risk with an increased creatinine of 1.5? This is something you just kind of have to know what it is. And that's why it gives you these really good clinical examples over on the right in your book, because someone that's at risk, a 68-year-old African American with CAD and CKD, type 2 diabetes, she's at risk. So that's why I included that, because when you're at risk, your creatinine's 1.5, or your urine output is less than 0.5 milliliters per kilogram per hour for 6 hours. Then your injury, so they've got an injury, then your creatinine goes up, and your urine output is less than 0.5 milliliters per kilogram per hour for 12 hours. Again, I wouldn't spend a lot of time trying to memorize every little detail about that, but just understand that when they're at risk, when their creatinine goes up, their injury showing that their creatinine, is elevated a little bit more, less urine output, and then of course failure, your serum creatinine goes up even more. They might not even have urine output for 12 hours. This could be someone 72 hours after surgery, they develop ventilator-assisted pneumonia and sepsis. So they're going into kidney failure. That's, pretty suddenly, right? 72 hours is 3 days. Why didn't you see it coming on? No, it can happen. And all this depends too on what kind of shape was the patient in before they had surgery. Did they have a lot of comorbidities, that kind of thing, Did they already have a little touch of CAD and maybe even pre-diabetic? And all of a sudden, they're in ICU, they've had surgery, and they're going into kidney failure. Well, they had a little bit of a predisposition. It can happen that way. So you got to think about, that's why history is so important. But you got to think about, that. And then loss is complete loss of kidney function for greater than 4 weeks. They started hemodialysis, and they can't even go into end stage. So back to acute kidney injury can turn into end stage kidney disease. It can turn into kidney failure, like long term. So that's just kind of understanding that. With waste accumulation, you can start seeing neurologic disorders such as seizures, coma, stupor, changes in mentation. So you may be having to do neurochecks on them. All that waste builds up and can cause problems neurologically. Again, your kidneys are not filtering out the waste. So then what does it do? Gets in your bloodstream, goes up to your brain. It can cause seizure, stupor, coma. So what are you going to see in the urine? Well, you may see casts, like I said, because of the acute tubular necrosis. You may see some white blood cells, red blood cells, protein. And your specific gravity will go up. What's a normal specific gravity? 1.003 to 1.030. Is that what your book says?
I know we want 10,
Yeah.
10.
10, 10.
Yeah, that's what I know.
10, 10. So sometimes your specific gravity will go up to 1.010, and it'll kind of be fixed there. If there's a lot. So what is specific gravity? What is that in your, what are we measuring for? Right, solutes, right? So if the kidneys are not filtering out the waste, then you're going to have more solutes, right? You're going to have more particles in your urine, basically.
What is the cast?
Cast, that is when you're, the acute tubular necrosis, when there's damage to the epithelial cells of the, then they slough off and create casts. So your oliguric phase, less than 400 milliliters a day, a reduction in urine output. This is your patient. You had a patient that had surgery. Let's just say they had a bowel resection, and all of a sudden they were peeing okay because they had a Foley catheter. It was removed. They're on a clear liquid diet, but they're still getting some fluids. And all of a sudden they're just not having any urine output. Red flag. Red flag, you gotta start investigating. Did someone not write down the right urine output? Someone forget to write it down, or are they just not putting out urine? They could be going into this oliguric phase. I used to work with a girl. She was, I'm thinking that she must have had a patient that died from kidney injury, because she was obsessed with the kidneys. She wanted to know every time how much their urine output was, and how, very specific. And, sometimes the urine, if they're not on strict I's and O's, sometimes that does get missed. It doesn't get put in the chart right. Someone forgets to chart it. But she was very, very obsessed about it. And the only thing I could figure is that she might have had a patient die from that. And often, even if it's not our fault, we still, a lot of times, we feel like it's our fault because we missed something, right? But anyway, so she was always really, really on point with the urine output. So that's something you just got to keep in mind, when you're taking care of someone, especially surgery patients, and definitely trauma patients. So this occurs 1 to 7 days of the injury, after the so it could happen 1 day after surgery, 7 days after surgery. It could happen immediate, 1 day, 24 hours, or 7 days later. And it lasts 10 to 14 days, and it can last even up to months. If it lasts longer, they have a poor prognosis. So back to our rifle chart, remember? Any kind of kidney loss greater than 4 weeks, they could go into chronic kidney, right? Or end stage. So they have a poor prognosis if it's not corrected. And I've got here, kidneys cannot synthesize ammonia. What is ammonia? It's your nitrogenous waste, right? Ammonia is formed when protein is broken down by bacteria in the intestines. Then the liver converts ammonia to urea, and then it's eliminated in the urine. So, the kidneys often can't synthesize that ammonia in this oliguric phase, and that's needed for the hydrogen excretion. So what do you get? Metabolic acidosis. Here we are again, back to metabolic acidosis. Kidneys cannot synthesize ammonia needed for hydrogen ion excretion. What does excretion mean? Get rid of. What gets rid of it? What gets rid of your hydrogen ions? The kidneys, but what's the bicarb?
So no more of that.
Well, it gets depleted because it's buffering, right? It's trying to get rid of it, but it gets depleted. So then you're going to have buildup, and you're going to have metabolic acidosis. What are some signs and symptoms of that? Metabolic acidosis. Cool smalls. Diarrhea. Drowsiness.
Hyperkalemia.
Nausea, diarrhea.
Good. All right. In severe acidosis, you're going to see Kussmaul's respirations. You're also going to have a problem. You're going to see some sodium imbalance. Because what happens? Back to my beginning when I was trying to tell you what each little area did, the distal, proximal tubule, all that. Well, the damage to the tubules can't conserve the sodium. Thus, you'll get abnormal levels of sodium. So you have a potassium excess. The kidney's normal ability to excrete potassium is impaired. So what are you going to see with a hyperkalemia? Peak T wave. Widening QRS. Muscle cramps. So now we're going to talk about the diuretic phase, and it's not as long. So the reason why the oliguric phase is longer is because you got all these problems happening, right? You got things that are happening due to your lack of to your damage to the kidney and to your lack of blood flow. So that's why you got all these problems. So then your diuretic phase is the ability for the kidneys to concentrate urine, or the inability for them to concentrate urine, but can excrete the waste. So it's getting rid of, it's not able to concentrate it. You got your a large loss of fluid and electrolytes. So you got to monitor for hyponatremia, hypokalemia, dehydration. So they're putting out all this water. But it's their electrolytes are still off, basically, if that makes better sense. So they can put out up to 1 to 3 liters daily, even up to 5 liters or more. So you got some osmosis going on here. Osmotic diuresis. They're getting rid of the fluid, just not concentrating it. So you want to monitor for hyponatremia, hypokalemia, dehydration. During this diuretic phase, your BUN and creatinine levels are still off, but they start, you might start seeing them normalize a little bit, but they're still off. This phase lasts 1 to 3 weeks. So if they're putting out a lot of urine or a lot of water, what do you think could happen with these people? Dehydration, hypovolemia. So they're going to be monitored closely. And then you've got your recovery phase. So the kidneys start filtering. So your glomerular filtration rate goes up. They're filtering correctly or better. And then you got your BUN and creatinine that begin to plateau and then decrease. And this is usually a 1 to 2 week process, but it can take up to 12 months. So they're the ones, they had an injury in the hospital, but yet they're going to need to follow up with their doctor so that they can monitor that everything's going back to normal and they're not going into chronic kidney failure, right? And their outcome is influenced by their overall health. Again, what kind of comorbidities do they have? Yes?
So someone may never reach this phase.
They may not.
And is this with interventions, or can your body may do this?
I would say they're going to need interventions. You got to treat the underlying cause.
Okay.
So whatever's causing the injury, you've got to treat it.
Okay. And so they might, like your patient, say they don't recover, they might be stuck in diuretic or in Auger.
Not necessarily. They won't necessarily be stuck there. They will eventually just go into loss and probably need permanent dialysis.
Okay.
So they can be stuck they can be stuck in this recovery phase for up to a year because the kidneys are trying to regain function, but you're monitoring them closely. You're doing labs. They're probably on some dietary restrictions, that kind of thing. And again, the outcome is influenced by the overall health. So were they healthy? Were they perfectly healthy before? They're probably going to have a better chance. Did they have some family history and they didn't, or maybe they had some CAD and they didn't know, or some hypertension and they didn't know? So what was their health like before that can influence how well they recover? So thorough history, serum creatinine. These are all the tests we're going to do. Like I said, we've already talked a little bit about all this as I've kind of went on. I've talked about it. Everybody that comes in the ER, they're going to get a urinalysis. But what do you think? What test do you think would be the least invasive on this page besides urinalysis? I mean, it's pretty simple. The ultrasound, right? Because all they're doing is taking a wand over you and checking you, right? So that's the least invasive. So that's the one that they'll often do because they can see the structure of the kidney. Is there any kind of tumor? Is there anything wrong? So kidney ultrasound is your least invasive first choice. Your book even talks about that they may do a CT scan, but your risk of your contrast-induced nephropathy, your CIN, can occur. So that is they don't normally do that.
Well, you don't have to use contrast.
You don't have to use contrast, but contrast just shows a better picture because it shows the flow. So if they're concerned about like renal flow, they can even do a renal scan, kind of like an MRI where they can do MRI. So there's plenty of tests that can be done. A renal biopsy often, say you've got someone with lupus or intrarenal failure, they can do a biopsy to check that tissue to see what's going on. Is it autoimmune? But your kidney ultrasound is your least invasive first choice. Yes. Does everybody have that? So, let's talk about treatment and collaborative care. Well, of course, our goal is to prevent complications, eliminate the cause, and manage your signs and symptoms, right? So initially, sometimes they'll give you diuretics. If your kidneys are not working at all, diuretics aren't going to work, right? But sometimes the doctors will do what's called a challenge, and they'll give you some diuretics to see if it'll get your kidneys to working. So it flushes the tubules and decreases the potassium.
So they might give a diuretic and they won't pee more. Is that what you mean?
Right.
So
They
does
could
that
give a
mean-
diuretic and hold on to it. Have fluid overload.
Okay, so then you would know the kidneys are probably pretty bad.
Yeah. But sometimes they'll do it. It's called a challenge where they'll try to see if they can get the kidneys basically to work or to get rid of some of this. And this is like for someone that's an injury. Someone that's in chronic kidney stage 4, they're not going to give them a diuretic because their kidneys aren't working. It's a progressive disease and they're just not working. But somebody, initially, they may try diuretic. You have to closely monitor them, eyes and nose. And you have to make sure that you think about their insensible losses. Does everybody remember insensible losses? What is insensible loss? You add 600, right? That's for your sweat, your tears, your anything, anything lost. You add your 600. It's your 24 hourly output plus 600. And then also, treatment, you're going to treat your hyperkalemia. We're going to talk more about this when we talk about chronic, but we have to talk about it now because it's part of the treatment for injury as well. Because if you got hyperkalemia, you got to get rid of it, right? You got to increase potassium. Well, also, the increase in potassium causes dysrhythmias. So your calcium gluconate helps decrease your dysrhythmias. Your insulin causes the cells to shift, causes the potassium to shift out of the cells. And you usually have to give some glucose with the insulin because they can have hypoglycemia.
Did you say we're gonna talk about?
We're gonna talk about this as well when we talk about chronic kidney failure, because anytime anyone has, this is a treatment. This is important to know, because there's a table too on it. 46.5, page 1073. Therapies for elevated potassium levels. 1073. So what's important to remember is your insulin, and usually with insulin you give glucose. It says here IV glucose is given concurrently to prevent hypoglycemia, because it causes the insulin can help move the cells, right? Move the potassium into the cells, get it out of the bloodstream. But it's temporary. It's only temporary. This sodium bicarb is temporary. Calcium gluconate is not treatment. It's more treatment for the dysrhythmia, right? But it's part of the treatment. Huh?
It's a prevention.
It's just a treatment. The calcium gluconate is just same thing. The calcium raises the threshold for the heart excitability. So these are just kind of temporary treatments. But what will actually remove the potassium is your sodium polycystyrene sulfate, Kayexalate. But, you know, it's important to know the generic sodium polycystyrene Kayexalate. And then you've got your Patiromer Veltessa also. It's an oral suspension. It's just another treatment for it. And dialysis. Dialysis will actually remove the potassium. So your top ones are your kind of temporary, but you know how long it takes to get anything done in the hospital, right? So you've got a patient and they've got a high potassium, and you're going to have to do something while you're waiting on them to go to dialysis, right? So you probably are going to have to do some of this temporary stuff before you can get them, before you can get that completely removed. Even the sodium, even the Kayexalate, you can give them an enema. It can go orally, but it takes some time to work. So, so just keep in mind that they may do, if you have a patient, they may do some of this IV stuff quicker and then do the other. It really depends on the doctor and what he orders, but this is a process, because you got to think, okay, if it's going in the mouth, you know how long does that take to work? An hour, right? It has to go through the GI tract. And they've got a dysrhythmia here. You don't want them to have a heart attack, right? So you might do something quicker, like an IV medicine, just to get a temporary shift, and then do your dialysis or do your sodium polycystyrene Kayexalate. So you got to think about that. You got to think, okay, well, this is going to take a while to work, so they may do something else first. Or let's just say the potassium's not that high. Let's say they don't have a dysrhythmia. They don't have a spiked T wave. Let's say the potassium's just 5 or whatever. But they're definitely having some injury to the kidney, so you know it's only going to get worse. Well, your doctor, say he's, zealous, and he's like, let's go ahead and get him some treatment. Well, he might go ahead and order the Kayexalate before it gets bad. So does that make because it's going to have time to work if they're not, about to have a heart attack. So, so it's not, you always got to think about what's going on with the patient. It's never black and white, right? So much gray area in nursing. Okay, dialysis. You may hear peritoneal or PD, hemodialysis, renal replacement therapy, CRRT, continuous renal replacement therapy. So there's several different ways you can dialyze someone. What is dialysis? That's just basically cleaning the blood, getting the waste out, getting the extra fluid out. It's cleaning the blood. Mrs. Ross is going to give you a great lecture on that next week. But it is a treatment for increased potassium and for kidney failure. Even kidney injury, sometimes they'll dialyze them for these reasons. Volume overload with symptoms. Volume overload with compromise. You're not just going to treat someone that's short of breath. You're not going to say, oh, they have to have dialysis because they're short of breath. No, they've got to have some compromise. Are their ABGs off? Do they have crackles? So volume overload that is compromised. This is important to know. Why would someone get dialysis? Volume overload, elevated potassium, pretty high elevated potassium, metabolic acidosis, a significant change in mentation or LOC. Do they have so much waste in their blood that they're just talking out of their head? They need dialysis. A significant, BUN increase to 120. That might be a reason to dialyze them. Pericarditis, pericardial effusion, cardiac tamponade. Any of those are reasons to dialyze someone. Nutrition, of course, that's important, right? Always. Ensure adequate calories, sodium restriction. If they're pretty sick and they need dialysis, well, chances are they might need enteral feedings or TPN. So just keep that in mind too. It depends on, how sick they are, but they do need adequate calories, because what happens with someone like this? Y'all remember the term catabolism? Protein muscle breakdown. They just kind of get emaciated because their muscles are breaking down. So they need good nutrition. All right. So nursing management, we're closely monitoring them. I's and O's. That will be vital for daily replacement. These patients, you can't forget to write something down. It's important. It's got to be a priority, right? You're going to assess urine color, labs, general appearance, lung sounds, JVD, jugular vein distension. What is that? What is that showing you? Jugular vein distension. Overload, right? What's a S3? Overload, right? A rub. What's a rub?
That's when the tissues are swollen and rubbing together.
Right. So pericardial effusion or pericarditis might have a rub. They may need an ECG because we're looking for that elevated T wave, right? You're going to evaluate their mental status. So what are they going to be on? They might be on neurochecks. Labs, BUN creatinine. Diagnostics, like we already talked about. Urinalysis, all that good stuff. If they're on dialysis, then you might have to monitor their site. So they were going to have a central line. So what kind of problems does a central line have? Infection. These patients, acute kidney injury, they often die from infection. Is it always the CVAD? Not necessarily, but it does help contribute to that. They're going to need skin and mouth care. And you're going to need to use aseptic technique because infection is the leading cause of death with AKI. Not going to spend a lot of time on these because they're pretty self-explanatory. Excess fluid volume, right? Related to kidney failure, fluid retention, risk for infection. Anxiety. Y'all need that? As far as nursing implementation, we got to recognize the risk factors, right? You taking care of patients, you need to, in the back of your mind, when you see comorbidities, you need to recognize risk factors. Careful monitoring and assessment. Again, assessment. Prompt replacement of IV fluids, eyes and O's. We're managing fluid and electrolyte balance during your oliguric and your diuretic phase. Follow-up appointments and teaching importance. When you discharge a patient, if they've had kidney injury, it's really important for them to follow up. Long-term appropriate referrals. Maybe they need counseling. Maybe they need nutrition, some nutrition guidance. So long-term referrals. And then psychosocial and financial hardship. It's stressful, especially if they're gonna need long-term, if they have long-term kidney problems, it can be very expensive. So they may need some financial counseling even. And then evaluation. Of course, we're evaluating what we did. Did it work? We, of course, would like for them to maintain fluid and electrolyte balance or regain it. We want them to be compliant. So how do we get someone to be compliant? Take them to a dialysis unit. Scare them to death? We got to create a relationship. That's why, it's real important to be relational as a nurse. If you become a advocate for your patient and you have a relationship with them, they are more apt to trust you and more apt to do what you say, what you think is important. Experience no untoward complications. So that would be, you got a patient that came in for surgery, they ended up having kidney injury. They had to get a central line. In evaluating their care, they're going home. They got the central line out. They didn't get an infection from the central line. They didn't get MRSA while they were there, so no untoward complications. And then have a complete recovery. And that's it.